I'm going to focus on care transitions in advanced dementia. And I must admit, I'm a social worker. I'm the founder of the Duke Center for Aging's Dementia Family Support Program. Of relevance to the dementia care transitions, I worked with the North Carolina HRSA grant team on materials preparing families for inevitable hospital transitions in advanced dementia. And we described the delirium risks in leaving individuals with dementia alone in an emergency room or hospital. Later, I joined an advisory panel operationalizing quality components of dementia-friendly hospitals. What I thought I knew professionally became personal last December. My husband of 55 years, a retired, honored clinician professor of family medicine, transitioned acutely twice, 1 week apart, from our continuing care retirement community's skilled facility to hospitals. And I should note both transitions happened on Friday nights during the Omicron surge, and my husband has advanced Lewy body dementia. I fully acknowledge that advanced Lewy body dementia's motor and swallowing issues are not typical. Not all people with advanced dementia have an available involved spouse over time, and continuing care communities reach only those with advanced planning and financial capacity. However, we chose a continuing care community based on my early professional assessment of the quality of the long-term care wraparound, or what Ruben calls comprehensive services. They were pivotal to the quality dementia care we received. We had a well-coordinated team of docs, social worker, PT, and nurses who knew us from responding to Bob's 10 non-injurious falls over 15 months during my care for him in our independent apartment. He moved to the skilled facility only when he could no longer stand or transfer without two-person plus a lift assistance. His first trip to the ED from the skilled facility was prompted by acute respiratory distress. Here's my first quality indicator. The skilled facility RN in charge that Friday night had me talk by phone to a geriatrician on call for his primary care doc before calling an ambulance. The doc guessed aspiration pneumonia, agreed with my insistence that he go to the dementia-friendly community hospital. But here's the first system problem. I had to overcome strong resistance from the protocol-driven ambulance EMTs who insisted that he go to the closer academic medical center. Second quality indicator happened when he arrived by ambulance and I arrived separately to approach the ED admissions desk. I knew to say the magic words. My husband has dementia. He can't be left alone. I was immediately able to meet him in the ED. The third quality indicator happened in the ED with the attending, who wisely reminded me that aspiration can happen again, leading to future hospitalizations. It might be time for a most form. His hospital room was family-friendly with a full bed for me, but despite an ideal environment, he encountered a major process problem. The hospital's aspiration protocol required that he be NPO awaiting swallowing evaluation. No speech pathologist was available for 3 days, and I should note Bob took great pleasure in mealtimes. A second brief process problem in this ideal hospital happened because his perfect skin care from the skilled facility deteriorated slightly because there was no recliner to transfer him to daily. After 3 days in bed with no meals or transfers, he had hypoactive delirium, despite my knowledge of risks and preventive strategies. When the speech therapist came the 4th day, she insisted on a barium swallow, which required a longer hospitalization, or return to the hospital by ambulance. I refused. The next quality indicator happened when he returned to the skilled facility. The skilled facility speech therapist actually observed me in his room, helping him through a long, arduous dinner process. She left practical, written, copied, and posted tips for me and the staff on how to help him eat and drink safely. Also, immediately after discharge, I completed a MOST form in consultation with his physician, and despite our best attempts, he was unable to participate or understand. The next Friday night, my informed planning met a system breakdown. I was called by a new RN in charge at night who said an ambulance was coming to the skilled facility for Bob, who was in acute respiratory distress. I literally ran across the campus to meet an EMT who insisted on transfer only to the academic center. All this despite a MOST form in the chart and my preference for the dementia-friendly hospital from before. I forced myself into the ambulance. That was our compromise. And upon ED arrival, the EMT said, "Well, just go sign him in and you can meet him in the treatment room." He lied. The waiting room receptionist said I couldn't see him until a nurse reported a negative PCR. After I spent 3.5 hours in a crowded waiting room, just by chance, his My Chart popped up on my iPhone noting a negative PCR. The receptionist still didn't budge because the nurse hadn't called to give me permission to enter. I pushed my way past security, only to find him looking terrified, a CPAP mask covering his face, leaning half off a gurney, and hooked to everything. I spent the next 12 hours sitting next to him on a rolling backless stool before I negotiated a direct admit transfer to the original hospital. In the interest of time, I'm going to summarize what's on my last 2 slides. If we could transfer to the next slide.
And Lisa, you have time, so take the time you need.
Oh, okay. Well, if I go back, I'll go back and just say that once we did get to the second admission in the dementia-friendly hospital, the admitting team, who was thoroughly familiar with him, recognized they could do nothing but order a pureed diet and a way to barium swallow. Well, Bob was not interested in a pureed diet. And he was discharged back to the skilled facility actually 8 hours after the second admission. So in summary, first bullet basically says, experience is going to change your goals and preferences. Second, the family can update, interpret, and provide context in a crisis faster than an epic chart. Third, quality dementia care must be led by clinicians and direct care staff with broad geriatric as well as dementia-specific skills. Fourth, only a family or representative of them can dependably follow an individual between care settings. Fifth, I learned that cordial, practiced working relationships between the hospital discharge planners and the skilled facility admissions nurses assured quality, safe transfers, particularly on medications. And the 6th and 7th bullets are all about constant communication, checking mutual understandings, and timely action. Thank you.